Welcome to the deep dive. I want you to start this journey with us today by doing a pretty difficult mental exercise.
It is a tough one, but really necessary to understand the stakes here.
Exactly. I want you to imagine someone you love deeply. Maybe it is your partner or a sibling or just a lifelong friend. Picture them healthy, vibrant, and completely themselves.
Right, just going about their normal life.
Yeah. Now, I want you to imagine a scenario where over the course of just 2 or 3 weeks, that person begins to slip away. And not from a physical injury you can see, but through a sudden, severe psychiatric break.
They start exhibiting intense paranoia.
Yes, they tell you the neighbors are spying on them. They begin having vivid visual hallucinations. Their behavior becomes erratic, completely uncharacteristic, and frankly, terrifying. Every single instinct you have, every pop culture reference you have ever consumed, and honestly, almost every conventional piece of wisdom in the medical triage system tells you that you are witnessing a mental health crisis.
You might think it is adult-onset schizophrenia.
Or perhaps a severe bipolar manic episode, or maybe even a drug-induced psychosis. But what if it isn't any of those things? What if this catastrophic loss of self is entirely a physical structural misfire occurring on a microscopic level?
What if their own immune system is quite literally attacking the very synapses of their brain that construct their personality, their memories, and their reality?
The scenario you are describing is one of the most harrowing experiences a family can endure. And for a very long time in the history of medicine, that specific presentation ended in tragedy.
It resulted in profound misdiagnosis. Patients exhibiting these sudden, terrifying symptoms were routinely locked away in psychiatric wards or asylums.
Heavily sedated.
Heavily sedated with antipsychotics that did absolutely nothing to address the root cause, simply because the underlying physical pathology was completely invisible to the technology of the time.
And that invisible pathology is exactly what we are dragging into the light today. Our mission for this deep dive is to map out an incredible, ongoing paradigm shift in how modern medicine understands, diagnoses, and treats a condition known as autoimmune encephalitis.
And why the traditional milestones of recovery are being completely rewritten.
To do this, you and I are going to unpack a massive stack of sources today. We have pulled excerpts from cutting-edge clinical guidelines and rigorous, large-scale studies published in the absolute heavyweight champions of medical journals.
We are looking at data from the Lancet Neurology, JAMA Neurology, and NEJM.
Spanning a critical decade from 2016 all the way to brand new, groundbreaking data from 2025.
The breadth of this research represents a fundamental earthquake in how we separate neurology from psychiatry. To truly appreciate the scale of this paradigm shift, you have to understand where the medical consensus was just a couple of decades ago.
Right, because historically, the medical community had a really narrow framework for understanding brain inflammation that wasn't caused by a direct infection like a virus or bacteria.
I know you were looking through the notes on the historical context earlier.
I was, yeah, and the terminology used in the older literature is fascinating. We used to view these rare conditions almost exclusively through a paraneoplastic lens. Let's break that down for the listener, because understanding what we used to think is the key to understanding why this new research is so revolutionary.
The term paraneoplastic essentially describes a syndrome or a collection of symptoms that is the indirect result of cancer in the body.
So the classic medical model assumed that if a patient presented with severe, non-infectious brain inflammation, there had to be a hidden tumor somewhere else in their body driving the process.
Exactly. The theory was that the immune system detected malignancy, say a lung tumor or an ovarian tumor, and mounted a fierce, appropriate attack to destroy those cancer cells.
But something goes wrong in the targeting system.
Precisely. The immune system is incredibly powerful, but it relies on recognizing specific protein structures or antigens on the surface of cells. In a paraneoplastic scenario, the tumor cells happen to express proteins that are structurally identical to the proteins found on healthy brain cells.
It is a biological case of mistaken identity.
That is exactly what it is.
Mm-hmm.
The immune system produces an army of antibodies designed to kill the cancer, but those same antibodies circulate through the blood, cross into the brain, and begin destroying healthy neural tissue as collateral damage.
That was the accepted model. You find the brain inflammation, you hunt for the cancer.
But here is where it gets really interesting. The sources make it abundantly clear that this old model was only showing us a tiny fraction of the picture.
The paradigm shift is the realization that we are dealing with a much, much broader autoimmune spectrum.
The research has unequivocally proven that the immune system does not need the excuse of a tumor to attack the central nervous system. A patient can develop an incredibly aggressive, brain-destroying autoimmune response spontaneously.
Nope.
No cancer, no hidden tumors. Just an immune system that inexplicably loses its tolerance for the body's own brain tissue and initiates a self-destruct sequence.
Which fundamentally rewrites the rulebook for doctors trying to figure out what is wrong with the patient sitting in front of them. If you can't just scan the body looking for a tumor to explain the crazy symptoms, how do you prove the brain is under attack?
Well, for a long time, the gold standard for proving anything was wrong with the brain was advanced imaging, specifically the MRI.
The assumption was simple, right? If there is a catastrophic fire burning through the brain's communication network causing seizures and psychosis, surely we will see the damage on an MRI.
We will see lesions, massive swelling, or visible structural degradation.
But the clinical guidelines we are reviewing today explicitly dismantle that assumption. They state that a completely normal MRI does absolutely not exclude the diagnosis of autoimmune encephalitis.
And that is because the damage occurring in these specific conditions is often synaptic and microscopic. The rogue antibodies are interfering with the chemical and electrical signaling between individual neurons. They're clogging up the microscopic receptors.
An MRI is a miraculous tool for finding gross structural abnormalities like tumors or massive strokes.
Right, large pockets of bleeding, things like that. But it cannot always see a microscopic chemical blockade at the synaptic cleft.
I want you to really let the gravity of that sink in. Put yourself in the shoes of a patient or a parent sitting in an emergency room a decade or two ago. The patient is hallucinating, unable to speak coherently, terrified. The doctor orders an MRI.
The family waits agonizing hours for the result, hoping for an answer.
And the doctor comes back and says, good news, the MRI is perfectly clean, the brain looks totally normal. But the patient is still screaming at entities that aren't there. Because the MRI was normal, the medical team concludes the issue is not physical, it must be purely psychiatric.
They're sent to a psychiatric facility, their physical illness completely ignored.
All because the imaging technology wasn't granular enough to see the invisible fire.
It represents generations of misdiagnoses and unimaginable suffering. And that profound realization that we cannot rely solely on finding tumors, and we cannot rely solely on an MRI, forced the neurological community to completely rebuild their diagnostic framework from the ground up.
If the traditional tools fail, how do you identify a disease that acts like a ghost? Okay, let's unpack this, because this leads us directly into the diagnostic puzzle. The medical community realized they needed a new roadmap, a way to diagnose this based on the clinical reality rather than waiting for an imperfect test.
And that brings us to the 2016 Graus criteria. The Graus et al. Criteria from 2016, published in the Lancet Neurology, is essentially the Magna Carta for modern autoimmune neurology.
Dr. Francesc Graus and an international panel of experts recognized that doctors in emergency departments were paralyzed.
They didn't know when to pull the trigger on heavy-duty, potentially dangerous immune-suppressing treatments because they're waiting for absolute proof. So the Graus criteria established a practical, tiered diagnostic approach.
The tiers are broken down into possible, probable, and definite autoimmune encephalitis. I find this structure fascinating because it acknowledges the reality of treating a human being in real time. Why is a tiered system so critical here rather than just having a definitive yes or no checklist from the start?
You have to consider the environment where these decisions are made. We are talking about fast-moving, high-stakes neurological emergencies. Imagine a patient arrives in the resuscitation bay, actively seizing.
Or perhaps their heart rate is wildly fluctuating and they're slipping into a coma.
The clock is ticking relentlessly. Time is literally brain tissue. Every hour that the immune system is allowed to rampage through the synapses, more irreversible damage is done. You simply do not have the luxury of drawing blood, sending it to a highly specialized out-of-state research laboratory, and waiting 2 weeks for a definitive antibody confirmation.
The patient could be dead by the time the mail arrives.
Exactly the problem the criteria sought to solve. The tiered system empowers the clinician. It provides an evidence-based framework to say, based on the constellation of physical signs presenting right in front of me today, this patient meets the criteria for possible disease, so I'm going to initiate these specific rapid tests.
Then, as MRI results, EEG data, or spinal fluid basic analyses, trickle in over the next 24 to 48 hours, they can upgrade the diagnosis to probable.
And hitting that probable tier is the green light.
That is the moment the medical team is authorized to start dropping the heavy artillery on the immune system long before the definite lab tests come back. It is clinical detective work designed to save lives in the gray area of medicine.
To illustrate how incredibly detailed this detective work is, the guidelines provide a very specific roadmap for diagnosing one of the most famous, aggressive, and widely studied forms of this condition.
Anti-NMDA receptor encephalitis. This specific subtype is an absolute beast, and walking through the criteria for it will really show you, the listener, just how baffling this disease is. According to the Graus criteria, the very first hurdle to clear for a probable diagnosis is the timeline. The onset has to be rapid.
Less than 3 months.
We are talking about progressing from a perfectly healthy baseline to severe life-altering symptoms in less than 3 months.
The rapid timeline is a vital differentiator. It helps clinicians separate this acute autoimmune attack from neurodegenerative diseases that smolder and progress over years, like Alzheimer's or Parkinson's disease. A sudden, violent storm in the brain over a few weeks strongly suggests an inflammatory or autoimmune origin.
Once the timeline is established, the clinician has to evaluate the patient against 6 major symptom groups. The criteria dictate that to hit the probable diagnosis threshold, the patient must exhibit symptoms from at least 4 of these 6 distinct groups. I really want to spend some time exploring each of these 6 because the sheer variety of ways this disease breaks the brain is astonishing.
It demonstrates the fundamental role of the NMDA receptor. These microscopic receptors are scattered throughout various critical regions of the brain. They are the communication hubs essential for learning, memory processing, and modulating behavior.
When rogue antibodies bind to these receptors and rip them out of the synaptic cleft, the downstream effects are catastrophic.
And vary depending on which brain region is currently under siege. Let's start with symptom group number 1.
Psychiatric and cognitive dysfunction. We touched on this earlier, but the clinical reality is jarring. The patient might start with subtle mood changes, maybe some unusual anxiety or insomnia, but within days, it escalates to profound delusions.
They might become convinced their family has been replaced by imposters. They experience terrifying visual and auditory hallucinations.
What is particularly dangerous about this first symptom group is how perfectly it mimics primary psychiatric disorders. A 20-year-old college student experiencing their first episode of schizophrenia might present in the exact same way.
Brought to the emergency department, agitated, perhaps combative, speaking to unseen people.
The standard medical protocol in many facilities is to medically clear them, which usually means a basic drug screen and a quick neurological exam that they might easily pass.
And then immediately transfer them to an inpatient psychiatric unit,
where they will be treated with antipsychotic medications, which, if their brain is physically under attack by antibodies, is like trying to put out a house fire by painting the walls a different color. It doesn't address the fire at all.
It delays the true diagnosis. And while they are sitting in the psychiatric ward, the disease inevitably progresses. This brings us to symptom group number 2, which is speech dysfunction.
The sources describe a staggering range of speech issues. This isn't just stumbling over a complicated word.
Not at all. The linguistic centers of the brain begin to misfire entirely. A patient might exhibit extreme pressure of speech, talking at a frantic, breathless pace, stringing together sentences that have zero logical connection, known as a word salad.
Alternatively, they might develop echolalia,
Or they lose the ability to generate original thought and simply parrot back the last words spoken to them. In severe cases, they progress to complete mutism. The architecture required to formulate and execute language simply goes offline.
Imagine the isolation. You are trapped in a reality warped by hallucinations, completely terrified, and suddenly the biological machinery required to ask for help just shuts down. It is a living nightmare, and as the inflammation spreads deeper into the cortex, symptom group number 3 often emerges, which is seizures.
The onset of seizures is frequently the critical turning point in the patient's journey. When a patient in a psychiatric facility suddenly experiences a generalized tonic-clonic seizure, the medical staff instantly realizes they are dealing with a severe physical electrical short circuit in the brain, not a primary mood or thought disorder.
It forces a transfer back to the medical or neurological intensive care unit.
Though even then, seizures in a young adult can sometimes be misattributed to withdrawal from illicit substances or an undisclosed overdose, further complicating the diagnostic timeline.
The clinical picture becomes even more bizarre with symptom group number 4, movement disorders. The specific term used in the literature is dyskinesias, and the presentation is visually striking and deeply distressing for a family to witness.
The NMDA receptors are highly concentrated in the basal ganglia, a deep brain structure responsible for smoothing out and coordinating our voluntary movements. When those receptors are blocked, the patient loses control over their motor pathways. In anti-NMDA receptor encephalitis, we frequently see intense orofacial dyskinesias.
Orofacial meaning the mouth and face.
Yes, the patient might exhibit constant, involuntary lip smacking, aggressive chewing motions, jaw clenching, or bizarre, repetitive grimacing.
The movement disorders can also manifest as choreoathetosis,
Which involves continuous dance-like writhing movements of the arms and legs, or severe dystonia, where muscles contract uncontrollably, twisting the body into rigid, painful, abnormal postures.
I am reading descriptions in these papers of patients who require heavy sedation purely to stop them from accidentally injuring themselves due to the violence of their involuntary movements. It is brutal. And if the progression isn't halted, the patient enters symptom group number 5, decreased level of consciousness.
The brain is essentially becoming exhausted by the constant electrical storm and the widespread inflammation. The patient might transition from severe agitation into a stupor.
They become lethargic, difficult to wake up.
Or they may enter a catatonic state where they lie perfectly still, staring blankly, completely disconnected from environmental stimuli, eventually progressing toward a deep coma.
And finally, symptom group number 6, which represents a direct threat to the patient's immediate survival: autonomic dysfunction. I always think of the autonomic nervous system as the body's hidden autopilot. It handles all the critical life support functions that you never consciously think about.
The brainstem controls that autopilot. When the autoimmune attack reaches the brainstem, the regulation of core bodily functions degrades rapidly. The patient might experience dangerous, unpredictable swings in blood pressure.
The heart rate might skyrocket to 180 beats per minute while they're lying completely still in a coma.
And then suddenly plummet to a dangerously slow rhythm. They can lose the ability to regulate their body temperature, spiking massive fevers with no underlying infection.
Most critically, they can experience central hypoventilation, meaning the brain simply forgets to send the signal to the lungs to breathe, requiring immediate intubation and a mechanical ventilator to keep them alive.
So those are the 6 devastating symptom groups: psychiatric, speech, seizures, movement, consciousness, and autonomic.
To pull this back to the Graus criteria for you, to establish that crucial probable diagnosis and unlock aggressive treatment, the physician needs to document a rapid onset of at least 4 of those 6 symptom groups. But that isn't quite enough on its own. They also need some supporting evidence.
The criteria state they need either an abnormal EEG, the brainwave test showing slowing or disorganized electrical activity,
Or an abnormal lumbar puncture, commonly known as a spinal tap, showing an elevated white blood cell count in the cerebrospinal fluid, indicating inflammation.
The criteria also provide an alternative pathway. If the clinical presentation is slightly less severe, say they only exhibit 3 of the 6 symptom groups, but the medical team discovers a systemic teratoma, that also satisfies the requirement for a probable diagnosis.
A teratoma. This is a concept that truly highlights how strange human biology can be. What exactly is a teratoma, and why is finding one an automatic trigger for diagnosing this specific brain disease?
A teratoma is a type of germ cell tumor, most frequently found in the ovaries of young women, though they can occur elsewhere. Because germ cells are the building blocks of the body, these tumors have the bizarre ability to develop different types of mature tissue within them.
A teratoma might contain hair, teeth, bone.
And, incredibly importantly, fully formed neural tissue actual brain cells growing inside the tumor in the ovary.
So you have a tumor in the abdomen that is essentially growing a tiny, disorganized brain.
The immune system detects this abnormal growth in the ovary and quite rightly recognizes it as a threat. It mounts an attack, creating antibodies specifically designed to target the neural tissue within the teratoma. The immune system is doing its job.
But those antibodies enter the bloodstream, circulate through the body, cross the blood-brain barrier, and find the patient's actual healthy brain.
The immune system cannot distinguish between the neural tissue in the tumor and the neural tissue of the skull. It attacks both with equal ferocity. That is why finding a teratoma in a patient with acute psychiatric and neurological symptoms is a smoking gun for the diagnosis.
That is mind-blowing biology. But this brings us to a massive, critical insight embedded in our sources. What happens if a patient has 4 of the symptom groups? They have an abnormal EEG. The doctor orders the highly specific blood and spinal fluid tests looking for the anti-NMDA receptor antibodies, and the tests come back negative.
This introduces the crucial concept of seronegative disease. The inclusion of seronegative guidelines is arguably the most vital safety net the modern medical community has constructed for these patients. Seronegative simply means that despite the patient exhibiting all the classic clinical signs of autoimmune encephalitis, the laboratory tests on their blood serum or cerebrospinal fluid failed to detect the specific pathogenic antibodies.
Wait, if the entire disease process is defined by rogue antibodies attacking the brain, how can a patient have the disease but test negative for the antibodies?
It requires acknowledging the limitations of our current scientific capabilities. First, the sensitivity of laboratory assays is not absolute. A patient might have pathological antibodies actively binding to receptors deep within the brain tissue, but the concentration of those antibodies floating freely in the spinal fluid might be below the detectable threshold of the machine running the test. You get a false negative.
So the test says no, but the brain is still on fire.
Furthermore, even if the test eventually comes back positive, these specialized assays often take weeks to process because they must be shipped to specialized neuroimmunology reference labs.
But the third reason is really fascinating.
Yes, the third and perhaps most fascinating reason for a seronegative result is the frontier of discovery. A patient might be suffering from a catastrophic autoimmune attack driven by a novel antibody, a specific protein target that medical science simply hasn't discovered, isolated, or named yet. You cannot test for an antibody you don't know exists.
If a doctor rigidly adhered to the old way of thinking, they would look at that negative lab result, shrug, and tell the family there is nothing they can do. The patient would be left to suffer irreversible brain damage, or worse, die, simply because a machine in a lab couldn't confirm what the patient's body was screaming.
And that is the brilliance of the modern guidelines. They explicitly state that doctors do not have to wait for, nor do they strictly require, a positive antibody test to save the patient's life. If the clinical presentation is loud and clear, the physician is authorized, even obligated to, initiate aggressive immunotherapy based on the clinical diagnosis of seronegative autoimmune encephalitis.
Imagine the profound relief of a family member sitting by a hospital bed. Their loved one is on a ventilator, experiencing constant seizures, completely lost to them. The doctor walks in and says the specialized test came back negative, or they are delayed. Your heart drops. But then the doctor looks at you and says, but we are not going to treat a piece of paper. The clinical picture is undeniable. We are treating the symptoms in front of us. We are starting the therapy today.
It is the ultimate triumph of clinical observation over strict reliance on laboratory values. And it perfectly sets the stage for why identifying the disease quickly is so paramount. It brings us to the concept of the golden window.
The golden window. Treatment and the 30-day cliff. Once that probable diagnosis is made, whether seropositive or seronegative, the medical team has to pivot from detective work to waging an all-out war. They must unleash a highly coordinated counterattack against the patient's own immune system. Let's look at the first-line immunotherapy arsenal detailed in the sources. There are three main pillars here: corticosteroids, IVIG, and therapeutic apheresis, commonly known as plasma exchange.
The strategy behind utilizing these three pillars is multifaceted. We should break down the mechanical concepts behind each one so you can visualize the distinct tactical goal each treatment achieves inside the patient's body.
Let's start with the heavy hitter that most people have heard of, corticosteroids. We are talking about massive, high-dose intravenous steroids, like methylprednisolone.
Corticosteroids function as the blunt instrument of immunosuppression. They deliver a broad-spectrum systemic command to the entire immune system to stand down. They cross the blood-brain barrier and rapidly reduce the gross swelling and edema within the brain tissue.
Furthermore, they actively alter the gene transcription within the hyperactive immune cells, forcing them to power down and stop producing inflammatory cytokines.
It is the equivalent of throwing a massive, heavy, chemical wet blanket over a raging fire. It doesn't necessarily hunt down the specific individual sparks, but it knocks down the overall flames very quickly.
Okay, the chemical wet blanket, that makes sense. Now what about the second pillar, IVIG, which stands for intravenous immunoglobulin?
IVIG is a fascinating, almost paradoxical therapy. You are taking cooled, sterilized, healthy immunoglobulins, meaning antibodies, extracted from the donated blood of thousands of healthy individuals and infusing them directly into the patient's bloodstream in massive quantities.
I have to stop you there because that sounds completely backwards. The patient is dying because their body has too many antibodies attacking their brain, so the medical solution is to hook them up to an IV and pump them full of thousands of more antibodies. How does that not make it infinitely worse?
It is a brilliant example of manipulating biological feedback loops. Think of it as a highly sophisticated distraction and neutralization tactic. By flooding the patient's vascular system with a massive tsunami of healthy, diverse donor antibodies, you overwhelm the immune system's receptors.
The rogue, disease-causing antibodies that are trying to get to the brain suddenly find themselves diluted and outcompeted.
The sheer volume of healthy antibodies binds to the destructive ones, neutralizing them. Additionally, the sudden spike in overall antibody levels sends a negative feedback signal to the patient's own B cells, essentially tricking the immune system into thinking, we have too many antibodies, halt production immediately. It hits the reset button through overwhelming numbers.
That is incredible, overwhelming the enemy with a decoy army.
Okay, what about the third pillar of the first-line defense, therapeutic apheresis or plasma exchange?
If steroids are the wet blanket and IVIG is the decoy army, plasma exchange is the physical cleanup crew. It is a highly invasive but remarkably effective mechanical intervention. The patient requires a large central line placed in a major vein. Their blood is continuously drawn out and run through a specialized machine that uses a centrifuge or a filter to physically separate the solid components, the red and white blood cell, from the plasma, which is the liquid portion of the blood.
And the plasma is the liquid medium where all those toxic rogue antibodies are swimming around. Precisely. The machine literally siphons off the toxic plasma and throws it into a biohazard bag. It replaces that lost volume with a clean, sterile substitute fluid, typically human albumin, mixes it back with the patient's own saved blood cells, and returns the scrubbed blood back into their body.
Over a series of several days, you are physically washing the rogue antibodies completely out of their circulation before they have a chance to cross into the brain.
It is an oil change for the blood.
And the beauty of the sources we are analyzing today is that we aren't just relying on theoretical mechanics. We have hard, unyielding data proving that these interventions work. I absolutely love when we get to look at the sheer scale of the evidence in these deep dives. Let's look at the Nocidini 2021 meta-analysis. For context, a meta-analysis is the pinnacle of medical research evidence. Researchers don't just run one study, they aggregate the data from dozens of smaller studies to create a massive, highly reliable statistical picture.
The Nocidini meta-analysis, published in JAMA Neurology, is a monumental piece of work in this field. They successfully aggregated outcome data for 1,550 individual patients suffering from anti-NMDA receptor encephalitis. In the realm of rare, complex neurological disorders, analyzing 1,550 patients provides a staggeringly robust, undeniable data set.
And the effectiveness they uncovered is jaw-dropping. Let's focus on therapeutic apheresis, that physical plasma exchange we just detailed. The Nocidini data revealed that utilizing therapeutic apheresis alone provided patients with a 5.6-fold increased odds of a good clinical outcome. I want you to appreciate the magnitude of that number in medical terms. 5.6 times more likely to recover and regain your life simply by mechanically washing the blood.
It serves as perfect clinical validation of the mechanical theory of the disease. If you physically extract the pathological antibodies from the system, you halt the damage. However, the study also prominently emphasizes that combination therapies are highly effective and often necessary.
Utilizing corticosteroids in tandem with IVIG, or aggressively hitting the patient with all three modalities simultaneously, steroids, IVIG, and plasma exchange, demonstrates excellent efficacy.
The clinical goal is to hit the hyperactive immune system with overwhelming force from multiple different physiological angles to force a remission.
But, and this is a massive flashing neon sign of a but hovering over this entire discussion, the efficacy of this entire first-line arsenal is entirely dependent on one unforgiving variable: speed, the golden window.
This is undoubtedly the gravest, most critical point we will discuss in this analysis. Timing is brain tissue. The Nocidini data makes the consequences chillingly clear. A lack of immunotherapy within 30 days of the onset of symptoms is associated with a 2.7-fold increased odds of a poor outcome.
Let's really dissect the reality of that timeline: 30 days. From the very first subtle, weird symptom, the moment the patient first feels unusually anxious or forgets a word, the clock starts. You have a strict 30-day window to navigate the medical system, secure a diagnosis, and get these heavy-duty, complex immune treatments physically running into their veins.
If you miss that 30-day mark, the chances of a poor outcome, which in this context means permanent, severe cognitive disability, lifelong institutionalization, or death, nearly triple. They become 2.7 times more likely to face a devastating end.
Why is it so incredibly difficult to hit that 30-day mark?
You have to map the typical patient journey we discussed earlier against that 30-day clock. The disease is a master of disguise. Consider week 1. The patient exhibits mild paranoia and insomnia. The family, naturally assuming a minor psychological issue or stress, waits a week to see if it resolves. That is 7 days gone.
Week 2. The patient suffers a full manic or psychotic break. They are rushed to the emergency room.
The ER physician evaluates a manic young adult, orders a standard toxicology screen, perhaps performs an MRI, which returns perfectly normal, and transfers the patient to an inpatient psychiatric facility. We are now at day 14.
And in the psychiatric facility, the focus is entirely on managing behavior. They are trying different cocktails of antipsychotic medications to stop the hallucinations. But those drugs do absolutely nothing to stop the immune system from destroying the brain.
The patient might languish in the psychiatric ward for another 10 days before the disease progression reveals its true nature. Perhaps on day 24, the patient develops a severe orofacial movement disorder or suffers their first tonic-clonic seizure. The psychiatric staff recognizes an acute neurological event, calls for an ambulance, and transfers the patient back to a medical hospital. A neurologist is consulted.
The neurologist recognizes the classic presentation, orders a lumbar puncture, and suspects autoimmune encephalitis. But by the time the spinal fluid is drawn and the decision to treat is made, you are sitting at day 28 or 29. That 30-day cliff is staring you right in the face, not because of medical incompetence, but simply because the disease's initial presentation deliberately misdirects the medical system away from the brain and toward the mind.
It is a harrowing race against the ticking clock, where the first half of the race is spent blindly trying to figure out which track you're supposed to be running on.
Let's look at the darker side of the treatment paradigm. What happens if the stars align? The family acts fast, the doctors are brilliant, they make the diagnosis on day 15, they hit the patient with massive doses of steroids, they run the IVIG, they do 5 days of plasma exchange, and the patient remains in a coma, still seizing. The first-line defense fails. What is the next move?
When the first-line therapies fail to halt the progression, the medical team must immediately escalate to the second-line defense. In modern protocols, that almost universally means introducing a powerful monoclonal antibody called rituximab.
The sources highlight rituximab as having a very specific superpower compared to the first-line treatments. How does this drug change the battlefield?
If the first-line treatment steroids, IVIG, apheresis, are focused on managing the immediate crisis, putting out the acute fire, and clearing the existing smoke from the room, rituximab is designed to permanently shut down the factory that is manufacturing the matches. Rituximab is an engineered antibody specifically designed to hunt down and bind to a protein called CD20, which is found almost exclusively on the surface of B cells.
And B cells are the specific type of white blood cell responsible for manufacturing all antibodies, including the rogue ones causing the disease.
Precisely. By targeting the CD20 protein, rituximab marks the B cells for destruction. It initiates a profound systemic depletion of the B cell population in the patient's body. By wiping out the biological factories, you completely halt the production of new pathogenic antibodies. It is a much deeper, longer-lasting, and more targeted suppression of that specific arm of the immune system.
And the statistics regarding its effectiveness are stunning. The data shows a striking 5.9-fold reduction in relapse risk when rituximab is administered. 5.9 times less likely to have this horrific disease come roaring back after you finally manage to beat it the first time. It isn't just a rescue therapy, it is a profound game changer for the patient's long-term survival and stability.
Which perfectly transitions our analysis into the next and arguably most complex phase of this deep dive. Surviving the acute burning phase of the encephalitis in the intensive care unit is a massive, miraculous victory. But once the fire is out, what happens to the scorched earth left behind?
That is the ultimate question for every patient and family, isn't it? So what does this all mean for actually getting better and going back to my life? We are moving into a deeply nuanced discussion about the concept of healing, and we need to look closely at the illusion of recovery and why the standard medical grading scales, specifically the MRS, are heavily criticized in recent literature because recovering from autoimmune encephalitis is absolutely nothing like recovering from a severe case of pneumonia or healing a compound fracture.
It requires a complete recalibration of patient and family expectations. The timeline for neurological recovery is extraordinarily prolonged. In general medicine, we are accustomed to conditions resolving in a matter of days, weeks, or perhaps a few months with physical therapy. Autoimmune brain injury operates on an entirely different calendar.
Let's look at the raw timeline statistics for anti-NMDA receptor encephalitis. The data indicates that roughly 75 to 81% of patients will eventually achieve what the medical literature categorizes as a substantial recovery. But the milestone for that recovery is at the 24-month mark. 24 months. 2 full years of grueling rehabilitation.
And 24 months is merely a benchmark. The clinical reality is that the microscopic repair of the synaptic networks, the rewiring of damaged neural pathways, can stretch out continuously to 36 months. 3 full years of ongoing, albeit slower, healing. We do observe that the steepest, most dramatic curve of clinical improvement typically occurs within the first 6 months post-treatment. But the brain's attempt to restore complex cognitive function continues for years.
This extended timeline brings us to a massive controversy highlighted in the brilliant 2024 study by Brenner and colleagues published in the journal Neurology. It forces us to ask, how do doctors actually measure if someone is recovered? To understand the controversy, we have to explain the tool they use. It is called the Modified Rankin Scale, or the MRS. This is the absolute standard grading tool used by neurologists globally to assess outcomes after major brain events.
The Modified Rankin Scale is a simplified 6-point clinical scale designed to measure the degree of physical disability or dependence in the daily activities of patients who have suffered a neurological injury, most commonly strokes or severe encephalitis. It ranges from 0 to 6. A score of 0 indicates a perfect outcome with absolutely no residual symptoms. A score of 6 indicates death.
Okay, so 0 is perfect, 6 is death. Where is the line for success? The literature states that a score of 2 or less is universally categorized as a favorable clinical outcome. Let's define a score of 2. The scale defines it as slight disability, unable to carry out all previous activities, but able to look after own affairs without assistance. Basically, the patient can walk unassisted, they can dress themselves, they can use the restroom alone, and they can exist independently outside of a nursing home.
To a busy neurologist holding a clipboard in a crowded outpatient follow-up clinic, checking boxes during a 15-minute appointment, an MRS score of 0, 1, or 2 looks like a resounding, massive medical success story. The patient arrived at the hospital months ago in a coma, having continuous seizures, and now they are walking into the clinic under their own power. By the metric of gross physical independence, they appear functionally cured.
But the Brenner study from 2024 drops an absolute bombshell that shatters that illusion of a cure. The researchers looked closely at a large cohort of these patients. They found that an incredible 91% of them achieved that coveted favorable MRS score of 2 or less after 36 months. 91%. If you just read the abstract, that sounds like one of the highest victory rates in modern critical care.
It appears victorious until you examine the twist. The researchers didn't just ask the patients if they could walk or dress themselves. They subjected these same patients, all of whom had favorable MRS scores, to deep, comprehensive, grueling neuropsychological cognitive testing. And the results were devastating. They discovered that despite appearing physically independent, 65% of those patients scored significantly below average in one or more complex cognitive domains.
65%. Almost 2/3 of the human beings who were explicitly told by the standard medical grading scale that they had achieved a good outcome and were recovered were actually suffering from profound, measurable, life-altering cognitive deficits. The data specifically points out severe ongoing struggles with working memory and executive language function.
Yes, the invisible deficits.
No. I want you to really relate this abstract data to your own daily life for a second. Imagine you survived this terrifying illness. You spent weeks intubated in the ICU, followed by a year of grueling physical therapy just to learn how to walk smoothly again. Your neurologist finally smiles, shakes your hand, and says, "Great news, your MRS score is a 1. You have a highly favorable outcome. You are officially recovered." So you try to go back to your life. But when you return to your office job, you realize you cannot hold 3 pieces of information in your head at once. You constantly forget the names of colleagues you have known for years. You sit in a meeting and struggle desperately to find the right vocabulary words to articulate a basic concept. You attempt to attend a crowded family gathering, and the overlapping noise and visual stimulation completely overwhelm your damaged brain's processing speed, triggering an acute panic attack that forces you to leave.
You raise the fundamental question of modern survivorship. What does it actually mean to be medically favorable if you can no longer perform the intricate cognitive tasks required for the career you spent a decade building?
Right.
What does it mean if you are physically capable of dressing yourself, but you no longer possess the mental stamina to read a novel, help your child with their homework, or manage your household finances without experiencing crippling neurofatigue?
It is the silent tragedy of looking entirely fine on the outside, but feeling fundamentally broken and not being you on the inside. The MRS scale entirely misses these invisible deficits because it wasn't designed to measure the nuances of the human mind.
This is precisely why the Brenner study, along with the foundational 2022 Graus study published in The Lancet Neurology, are so critical to changing the paradigm of post-hospital care. They systematically document and list the invisible deficits that the MRS is completely blind to. The standard neurological scale does not measure a patient's emotional well-being. It utterly fails to capture the severe, treatment-resistant anxiety or profound depression that frequently lingers long after the acute inflammation is gone, often caused by the direct damage to the brain's emotional regulation centers.
Furthermore, it completely misses the degradation of social functioning. It doesn't measure a patient's newly diminished ability to maintain complex interpersonal relationships, read subtle facial expressions, or navigate the unwritten rules of social cues.
It also ignores energy levels. Pathological neurofatigue is a massive debilitating issue for these survivors. Because their neural pathways are damaged, their brain has to work 10 times harder, utilizing inefficient rerouted connections just to process normal, everyday environmental stimuli. This leaves the patient physically and mentally exhausted, essentially running on empty by noon every single day. Ultimately, the MRS fails entirely to capture the patient's overall subjective quality of life. The patient feels fundamentally altered, struggling daily, yet the medical system points to a score of 1, gives them a gold star, and formally discharges them from specialized care.
It requires a paradigm shift not just in how doctors diagnose the fire, but in how society and the healthcare system validate and support the patient's lived experience of the aftermath. We have to look far beyond gross motor skills and basic physical independence markers. We have to start treating the nuanced, microscopic, highly individualized cognitive reality these survivors are facing.
Which serves as a perfect transition into understanding that the journey is not uniform. We must examine diverging paths, because the road to recovery is never a straight, predictable line. It diverges wildly depending on the root cause of the initial brain inflammation, the age of the patient, and the ever-present threat of the disease returning.
Let's bring some incredibly fresh, cutting-edge data into the conversation to highlight these diverging paths. We are looking at a brilliant 2025 study by Sonneville and colleagues, published in JAMA Network Open. This specific data set focuses on critically ill adult patients who suffered from acute encephalitis, and it meticulously tracks and compares their cognitive and functional recovery trajectories over an extended period.
The contrast they uncovered between different types of encephalitis is paradigm-altering for rehabilitation medicine. They compare the recovery curve of autoimmune encephalitis against infectious encephalitis, which is severe brain inflammation caused by a direct viral or bacterial invasion, such as the herpes simplex virus attacking the temporal lobes.
What does the recovery curve look like for someone who survives the infectious type?
For patients who survive viral or infectious encephalitis, and indeed for many other acute neurological injuries like severe strokes or traumatic brain injuries, the data clearly shows a distinct trajectory. Patients tend to improve rapidly over the first 90 days post-injury, but then they hit a pronounced functional plateau at roughly the 3-month mark. Their healing curve flattens out. Generally speaking, whatever neurological deficits they still possess at 3 months are highly likely to be the permanent deficits they will carry forward for the rest of their lives. The active biological healing process largely ceases.
But the JAMA Network Open data reveals that autoimmune encephalitis is an entirely different biological beast. The study demonstrates that autoimmune cases do not hit that 3-month wall. Instead, they show statistically significant, continued functional and cognitive improvement through a full year, and as we discussed earlier with the anti-NMDA receptor-specific data, that upward trajectory can continue for up to 36 months. The healing curve keeps going up long after the infectious patients have plateaued.
The practical implications of this differing trajectory are massive, particularly when you consider how the healthcare and insurance systems operate. If a physical therapist, a cognitive rehabilitation specialist, or an insurance adjuster treats an autoimmune encephalitis patient exactly the same way they treat a stroke patient or a viral encephalitis patient, they will likely mandate discharging them from the rehabilitation program at month 3 or 4. They will look at the calendar and conclude, well, standard medical doctrine says they have plateaued. This level of function is as good as it gets. Therapy is no longer medically necessary.
But they haven't plateaued. They're simply running a marathon while the system is designed to support a sprint. They're just getting started on a much longer, infinitely slower process of neural rewiring.
Exactly the issue. This data highlights the desperate, critical need to overhaul our rehabilitation protocols. It proves the necessity for extended, highly specialized cognitive and physical rehabilitation specifically tailored for autoimmune cases. You cannot arbitrarily cut off their therapy at month 4. These patients require ongoing, rigorous cognitive training, psychological support, and occupational therapy spanning years, not months, to maximize their brain's unique ability to eventually rewire those damaged synaptic connections. If the system cuts off their support prematurely based on outdated models, we are literally robbing them of their ultimate recovery potential.
That is such a vital takeaway for anyone navigating the aftermath of this disease. You have to fight for extended care because the data proves your brain is still healing. And speaking of entirely different trajectories, we also need to briefly touch on how this disease affects a very specific, incredibly vulnerable population: children. The clinical guidelines clearly dedicate sections to pediatric considerations.
Autoimmune encephalitis does not discriminate by age. It can absolutely strike toddlers, young children, and adolescents. And it presents a uniquely tragic set of challenges in the pediatric population. One of the most critical universal findings across pediatric studies is that early aggressive immune treatment in children is highly, unequivocally associated with significantly better long-term outcomes. The developing brain is a paradox. It is incredibly plastic and highly resilient, possessing a remarkable ability to reroute functions, but simultaneously, it is exquisitely sensitive to any inflammatory disruption during critical developmental windows.
And their path to cognitive recovery looks fundamentally different from an adult's, right? Because an adult is trying to fix a machine that was already fully built, whereas a child is trying to fix a machine while it is still under construction.
That is an excellent way to conceptualize it. An adult patient who suffers from cognitive deficits is attempting to recover established, deeply ingrained baseline skills, their vocabulary, their professional expertise, their emotional regulation strategies. A 7-year-old child's brain is still actively developing those fundamental baseline skills. They are still learning how to read, how to execute complex problem solving, and how to manage interpersonal relationships. Therefore, a severe episode of autoimmune encephalitis doesn't just damage existing skills, it can completely stall or permanently derail their entire developmental trajectory.
Which means their rehabilitation cannot just happen in a clinic. It has to be deeply, seamlessly integrated with their educational framework. The school system has to understand that a child recovering from this might look completely normal, but they are battling an invisible brain injury that fundamentally alters how they acquire new knowledge.
It is a heartbreaking reality for families to navigate, but it is also infused with hope, knowing that swift medical intervention and highly specialized long-term educational support can salvage their developmental future. However, there is a dark cloud that hangs relentlessly over every single patient, whether an adult or a child, who battles and survives this disease. And that brings us to the final, sobering set of statistics we need to discuss: the shadow of relapse.
Relapse is the terrifying reality that even after a successful initial treatment, after months of grueling recovery, and after the patient finally starts feeling like themselves again, the immune system can suddenly switch back on, manufacture new antibodies, and launch another devastating attack on the brain.
The combined sources state clearly that clinical relapse occurs in approximately 12 to 25% of all patients. 12 to 25%. That means that up to 1 in 4 patients who survive the initial horrific ordeal will eventually have to face the nightmare of fighting this monster all over again.
What triggers the immune system to suddenly break the truce? Why does the disease come roaring back in that 25%?
The clinical data points to a few major identifiable risk factors for relapse. The most prominent and dangerous risk factor is failing to identify and remove a hidden underlying tumor. We return to the concept of the teratoma. If a young woman develops anti-NMDA receptor encephalitis driven by a microscopic teratoma hidden in her ovary, the medical team might successfully treat the acute brain inflammation with high-dose steroids and plasma exchange. The patient will likely improve dramatically because the immediate circulating antibodies were washed away. However, if the medical team fails to locate and surgically excise that teratoma, the underlying root cause remains. The tumor will simply continue to grow, continue to express neural proteins, and continue to constantly provoke the immune system. Once the immunosuppressive drugs wear off, the encephalitis will inevitably, predictably return.
So, rigorous, comprehensive, and sometimes repeated cancer screening using the most advanced imaging available is an absolute mandate. You have to find the match that started the fire. What is the other major risk factor for relapse?
The second major risk factor identified across multiple studies is the failure to utilize second-line immunotherapy during the initial presentation of the disease. This brings our discussion squarely back to the profound importance of rituximab.
Right. We talked about rituximab earlier, acting as the targeted biological weapon that seeks out and destroys the B cells, shutting down the antibody manufacturing factories.
Let me remind the listener of that striking statistic from the literature. The administration of rituximab offers a massive 5.9-fold reduction in the risk of future relapse. Because of this undeniably powerful protective effect, we are witnessing a significant shift in modern clinical guidelines. Historically, rituximab was held in reserve, treated as a Hail Mary pass only deployed when the first-line treatments completely failed. Today, it is increasingly being utilized earlier, more aggressively, and more routinely, specifically to crush this long-term relapse risk and secure the patient's future stability. The evolving philosophy is, don't just put out the fire once, dismantle the factory so the fire can never start again.
It is all about long-term strategic warfare against a hyperactive immune system. When you step back and look at all these intricate pieces we have unpacked today, the revolutionary Graus criteria allowing doctors to act on clinical symptoms rather than waiting for lab tests, the unforgiving 30-day golden window for immunotherapy, the heartbreakingly long road of invisible cognitive deficits ignored by the MRS scale, and the ongoing battle to prevent relapse. It is truly astonishing to consider how far the medical field has advanced in just a single decade, and yet it is equally astonishing how infinitely complex the human body remains.
It is a deeply humbling field of scientific study. The more we learn about the intersection of immunology and neurology, the more it forces us to constantly, rigorously question our foundational assumptions about the mind, the structure of the brain, and the hidden power of the immune system.
As we draw this deep dive to a close, let's do a rapid-fire recap of the massive intellectual journey we have just taken you on through these incredible medical sources. We started by mapping out the sweeping paradigm shift away from purely paraneoplastic definitions, arriving at the empowering understanding that autoimmune encephalitis can strike absolutely anyone spontaneously, with or without underlying cancer, and that a perfectly normal, pristine MR means absolutely nothing when diagnosing this invisible microscopic fire burning in the synapses.
We meticulously deconstructed the brilliance of the Graus criteria. We saw how it gives frontline emergency doctors the critical permission to act immediately based on the clinical presentation of severe psychiatric and neurological symptoms, utilizing the vital seronegative safety net rather than waiting for slow, imperfect laboratory tests to confirm what they already see happening to the patient.
We highlighted the absolute, unforgiving necessity of the 30-way treatment window. We established that the medical team has to hit the immune system with steroids, IVIG, or therapeutic apheresis before that 30-day cliff, where the odds of a devastatingly poor outcome skyrocketed by 2.7 times. And we pulled back the clinical curtain on the hidden realities of cognitive recovery. We saw exactly how the traditional MRS grading scale creates a dangerous illusion of recovery, masking the profound, life-altering memory and executive language deficits that a staggering 65% of physically recovered patients still struggle with years after discharge.
Ultimately, the enduring value of analyzing this specific stack of research is realizing the critical ethical importance of looking far beyond standard generalized metrics. We must demand that the healthcare system treats the nuanced clinical reality of the individual patient in front of us. We have to fiercely advocate for long-term specialized rehabilitation that acknowledges the patient's unique, extended healing trajectory, especially given the clear data showing autoimmune cases improve for years longer than infectious ones.
We have thrown an immense amount of heavy biological science, intense statistics, and complex medical history at you today. But before we sign off, I want to address you directly with a parting idea to mull over. It is something that builds on the subtle hints scattered throughout these medical journals and touches on a much deeper, almost philosophical mystery about who we are.
The broader implications of what we have discussed today truly extend far beyond the mechanics of just one rare neurological disease.
Exactly. I want you to think deeply about the profound concept we kept coming back to: antibody-mediated synaptic dysfunction. We are talking about physical, biological, rogue antibodies literally crossing the blood-brain barrier and chemically interfering with the microscopic synaptic clefts, the very physical electrical connections in your brain that literally construct your memories, generate your personality, and dictate your mood. We are talking about the physical connections that make you. If a singular random immune system glitch can completely alter a human being's psychiatric reality, their behavior, and their entire memory structure in a matter of weeks, what else about human consciousness and mental health might actually be rooted in the hidden microscopic battles of our immune system? Could some forms of severe treatment-resistant depression or crippling generalized anxiety or other profound psychiatric conditions that we currently view purely as chemical imbalances or psychological traumas actually have an unrecognized systemic immune component playing out silently in the shadows of our biology?
It is a vast, largely unexplored frontier of modern medicine that we are only just beginning to map with the proper tools. The rigid historical line between the discipline of immunology and the discipline of psychiatry is blurring more and more every single day with every new study published.
It is absolutely something to keep your mind completely radically wide open about as science pushes forward. We want to profoundly thank you for taking the plunge into these incredibly complex, deeply human sources with us today. It is a heavy, intense topic, but truly understanding the mechanics of it permanently changes how we view both the terrifying fragility and the breathtaking resilience of the human mind. Keep questioning the obvious, keep looking deeper into the science behind the headlines, and most importantly, stay curious.